Welcome. Thank you so very much for giving up part of your evening to attend this webinar. It's great to have so many of you here. I'll start by introducing myself. My name is Jessica Woodhouse, and I'm the Head of Patient Safety, Human Factors and Quality here at the Ralph. To our knowledge, we're the only referral hospital to have a full-time role dedicated to all things patient safety, human factors and quality improvement. And I'm supported by a veterinary nurse, Amelia, who works with me part-time, and I know is on the call this evening. I'm non-clinical, but I work very closely with clinical teams in my role. My background is as a quality improvement specialist, and I spent the majority of my career in the public sector, in both local government and the NHS, where I've worked in primary care, a large teaching hospital, and a mental health trust. I came to the Ralph 2 years ago, next week in fact. This is my first role in the veterinary setting. I'm not a specialist in psychological safety by any means, but I do have lots of experience and qualifications in things like Lean Six Sigma, service improvement and redesign, and business management, all of which encompass the various aspects that are necessary to create the conditions where we get the best outcomes possible for our patients. My work in human healthcare and in quality improvement has shown me that teams perform best when people feel safe to speak up, and the same applies in veterinary practice too. I'm also a dog mum to Chewy, pictured here with me. I very much believe that our animal companions deserve the very best safe and quality care that any of our family members do. So in this evening's session, the webinar is titled Safer Patients and Stronger Teams, and explores the power of psychological safety in veterinary practice. We'll explore what psychological safety looks like, why it matters, and particularly in our context. We will look at how psychological safety helps us as individuals and as teams, and also how it helps our patients. We will explore some of the barriers to psychological safety, and then take a practical look at what we can do to help create an environment of psychological safety in our own practice. This session is being recorded and will be published on the Library and Learning section of the Ralph's website, where all of our previous CPD events are also published. So I encourage you to go back and review some previous sessions for some excellent free CPD. And as Tony said, we do have questions enabled, so please add any questions, submit them there, and we'll have time to go through some of them at the end. We'll then move on to talking about what is psychological safety. So I've got another poll for you to do. We'll have some questions come up on the screen. Let's hope it works okay as well. So yes, you've got 3 questions coming up on your screen. We've got, how comfortable do you feel? Oh, again, by the way, these are anonymous, so we won't know who said what and what your answers have been. So how comfortable do you feel asking a clarifying question in front of your team? Have you ever stayed silent at work, even though you had a concern? And what feelings or responses have you experienced when you've made a mistake? Give a bit of thought and reflection to that. And the third question there is a free text answer, so you can just type in what you've experienced in relation to errors that you may have made in the past. A really sort of mixture there of people's different comfort levels in asking questions in front of their team members. Some people very comfortable, others less so. People being very, very brave and honest about the fact that they have stayed silent at work, even though they've had concerns, either once or twice or many times. I can't actually see the answer to the third question, so we'll have a look at those another time. So, but thank you again for being willing to share those responses. Even without seeing individual answers, what we usually find in groups like this is a bit of a mix, with some people feeling comfortable speaking up, many only sometimes, and a lot of people can remember a moment that they stayed silent or felt uncomfortable after an error. That's exactly why we're talking about psychological safety. These experiences aren't about individual confidence or personality. They're signals about the environment we work in and the level of social risk people feel in everyday situations. Because in healthcare and in veterinary practice, these moments of hesitation don't just affect us emotionally, they can affect decisions and communication and ultimately patients. So let's have a little bit of a look at what this looks like in real life. I'm going to share a clinical example where someone noticed something that didn't feel right, and we'll explore what psychological safety or lack of it might mean in that situation. So our team has just finished surgery on a dog, and at the end of the procedure, the vet gives an order to the nurse to give cefuroximine every 2 hours for post-operative infection prophylaxis. The veterinary nurse taking the instruction feels that the timing seems unusually frequent, as it's usually given every 8 to 12 hours. So cefuroxime every 2 hours, that seems a bit too much. The vet is very experienced, so maybe there's a reason. And not want to slow things down at the end of a very long surgery. So the nurse hesitates to question the vet and considers administering as prescribed. There are patient safety risks in this scenario, mainly from higher than intended dosing of antibiotics, which could lead to gastrointestinal upset. And the psychological barriers that might prevent the nurse from speaking up include hierarchy, the fear of challenging a vet, but might also be from the time pressure immediately after surgery, or concern about feeling inexperienced or appearing inexperienced, or appearing disrespectful, thinking that the vet must know better. Psychological safety would improve the outcome if the nurse feels safe to clarify or double check, which would lead to the vet adjusting the order and also documenting the near miss for team learning. So here is a definition from Amy Edmondson, who's one of the leading researchers on psychological safety. Definition is: psychological safety is a shared belief that the team is safe for interpersonal risk-taking, meaning individuals can feel they can speak up, ask questions, or admit mistakes without fear of humiliation or punishment. Let's break that down a little bit more, though. So a shared belief. It's not just about one person feeling safe, the entire team has to. It's a team-level phenomenon. Everyone needs to perceive the environment is safe to speak up in. Safe for interpersonal risk-taking. So speaking up and asking questions and admitting uncertainty or highlighting potential errors is considered socially risky. Psychological safety reduces the fear of any negative social consequences. Individuals feeling they can speak up. So an environment that encourages reporting errors, raising concerns and questioning decisions. This applies to all roles: vets, nurses, patient care assistants, reception and non-clinical staff. Ask questions or admit mistakes. So this emphasises learning from errors rather than blaming individuals and supports continuous improvement and patient safety. And without fear of humiliation or punishment. This is critical for creating a culture where near misses or small concerns are shared and encourages proactive safety behaviours rather than silence. So in short, psychological safety is an environment where people have permission to speak up without fear. This could be a fear of a lot of things, which many of you may have mentioned these in our poll earlier. So the fear of blame, the fear of ridicule, the fear of judgment, the fear of being wrong, the fear of embarrassment, the fear of failure, the fear of slowing things down, and the fear of the impact on your career progression. So a book was published in 2020 called The 4 Stages of Psychological Safety, Defining the Path to Inclusion and Innovation. This sets out a model that helps to understand how team members experience safety in different ways and describes how psychological safety develops in the team and what people need to feel safe at different levels of interaction. So our 4 stages are, starting with inclusion safety. So that's this sense of genuine belonging, acceptance and respect, feeling safe to share perspectives and to participate, and feeling valued and respected. So team members with inclusion safety feel accepted and included for who they are, and everyone can take part without feeling they could be ignored or excluded. So an example might be a new veterinary nurse feels comfortable joining the ward handovers. Next, we have learner safety. So people feeling it's a safe environment for learning and growth, that we encourage risk-taking and experimentation, and that we embrace mistakes as opportunities for improvement. So with learner safety, team members feel safe to ask questions, to seek feedback, or admit they don't know something. Mistakes are seen as learning opportunities and not weaknesses. So an example might be a student nurse asking for clarification about a medication dose. Then with contributor safety, this means people feel empowered to contribute their skills, their knowledge and their ideas. It's a sense of cultivating ownership and accountability and autonomy among our teams, and it increases engagement, motivation and productivity. So with contributor safety, team members feel safe to offer their ideas and suggestions and recommendations. Their contributions are respected and considered, even if they're not adopted. So an example might be a vet nurse suggesting a change to how patient handovers take place in the practice. And next, the highest level is what we call challenger safety. So team members feel safe to challenge, safe to express their opinions and propose ideas. It's a precondition for innovation and continuous improvement and debate. And it encourages critical thinking. We challenge assumptions and push some boundaries a bit further. So with challenger safety, team members feel safe to challenge the status quo, to question decisions, or to raise concerns. Critique is encouraged when it improves patient safety or outcomes. So the example would be the nurse questioning the vet's post-op antibiotic timing that seems unusually frequent. So with inclusion safety, I feel accepted as part of the team. With learner safety, I feel safe to ask questions and admit mistakes. With contributor safety, I feel safe to add my ideas and suggestions. And with challenger safety, I feel safe to challenge decisions and raise concerns. This model highlights that psychological safety is not a single state, it's a series of layers that build on each other. Each stage represents a different type of interpersonal risk that people must feel safe taking. And it shows that simply being included isn't enough to support patient safety. Teams must progress through the stages to enable learning, contribution, and safe challenge. And in veterinary practice, this means all staff, from receptionists to vets, being able to speak up about concerns, to prevent errors, and to improve patient outcomes. I also want to reflect on what psychological safety is not. So it is not a nice to have or a soft concept. It directly affects team performance and patient safety, which we will explore further through the session. Teams without psychological safety are more likely to experience errors, to have miscommunication and near misses. It's not the same as being friendly or agreeable. Team members can disagree, challenge ideas, and raise concerns. Conflict and debate is okay when done respectfully and constructively. It is not a free pass for poor performance. Accountability, standards, and competence still matter. Psychological safety means staff feel safe to admit mistakes or ask for help, not just to avoid responsibility. It's not just about feeling good. It's about safety for speaking up and taking interpersonal risks, not just about happiness or morale. Feeling safe enables learning, error prevention, and innovation. And it's not the absence of hierarchy or structure. Teams can have leaders, senior staff, and structured roles. Psychological safety works within hierarchies, allowing staff at all levels to question, clarify, and contribute without fear. So why does it matter? I want to start by talking about Project Aristotle. This was a multi-year research study done by Google to understand what makes teams effective. So they analysed over 180 of their teams across the whole company, looking at people's traits and behaviours and the outcomes from those teams. And surprisingly, who was on the team didn't matter as much as how the team worked together. Teams with high psychological safety consistently outperformed those without it. Members in these teams felt safe to speak up about mistakes, to ask questions, to offer new ideas, and challenge decisions. But conversely, teams with low psychological safety hid errors and avoided speaking up and underperformed, even if team members were highly skilled. This matters for veterinary teams too. Patient safety depends on everyone speaking up when they notice a risk, no matter what their role is. And just like in Google's teams, technical skill alone isn't enough. The culture of safety and openness determines whether errors are caught early. Psychological safety allows junior staff and nurses and receptionists and students to raise concerns without fear, which directly protects patients. There are some published research papers in the veterinary space now that touch on these themes. This paper from 2015 is We Need to Talk About Error. It's a study into the causes and types of error in veterinary practice. They used data from over 2,000 VDS claims and also looked at a case review of 12 months worth of VDS insurance claims, and also held focus groups with a number of people from different small animal and mixed practices. They found in this study that the majority of errors in veterinary practice are due to cognitive limitations or non-technical skills. This study provides some empirical evidence of the effect that poor leadership, communication, and teamwork can have on patient outcomes and the quality of care. It highlighted the importance of non-technical skills in the veterinary profession and provides a systems perspective on errors. And the paper recommends that we should do more CPD in non-technical skills, such as interprofessional communication, clinical leadership, and teamwork. This paper here is a more recent paper from last year on navigating veterinary error disclosure, explores the relationship between humble leadership, psychological safety, safety climate, and attitudes to error disclosure among veterinary professionals. So leadership styles and safety culture have been extensively examined in other sectors, but comparable research really remains scarce in our veterinary sector. So by humble leadership, they mean leaders acknowledging their own limitations and highlighting the juniors' strengths and promoting learning in their teams. And the study found that the perceptions of humble leadership are significantly associated with psychological safety, and in turn, that's linked to more positive attitudes to error disclosure. The paper recommends that veterinary organisations should invest in leadership development programmes that emphasise humility, self-awareness and openness. It highlights that promoting psychological safety among all team members is crucial and shows that creating a supportive culture that views errors as learning opportunities can encourage staff to report and learn from mistakes. So essentially, we can think of psychological safety as the ballast in a ship. The ballast keeps it steady and prevents it from capsizing in rough waters. In the same way, psychological safety is the ballast for our teams. It provides stability even when challenges arise. So how does psychological safety help us as individuals and as teams? I run induction sessions for all of our new starters here at the Ralph, and one of the questions I ask is, what are the ingredients of a good day at work? And this word cloud shows the things that get mentioned, and with the bigger the word, the more often it gets mentioned. And you can see the things that make a difference to team members in their day, many of which link to elements of psychological safety, such as teamwork, communication, positive attitudes, learning, and leadership. Let's take a deeper look now into how psychological safety helps us as veterinary teams and as individuals. It reduces stress and mental load. So we're not wasting mental energy worrying whether we'll look stupid or if we'll get in trouble for asking. It frees up that brain capacity for clinical reasoning, for monitoring patients, and for decision making. And if our mind feels safer, this will lead to a better clinical performance. It makes communication easier and faster. People will ask clarifying questions early. Misunderstandings will get corrected much sooner, and there'll be less silent guessing. All of this results in fewer delays and fewer assumptions and smoother workflow. It supports learning, growth, and skill development. Staff can say, I'm not sure. Can you show me? I made a mistake. Students, trainees, new graduates, and new employees will learn faster. Experienced staff continue improving, and a psychologically safe team becomes a learning team. It strengthens teamwork and trust. People believe colleagues have good intentions. There's less blame, which means there's more problem solving. It's easier to ask for help during busy or complex cases. And teams move from covering yourself to covering each other. It makes speaking up feel possible. Staff raise small concerns, uncertainty, and those something doesn't feel right here moments. Issues are addressed earlier when they're generally easier to fix. And small voices early on can prevent big problems later. It protects well-being and morale. There's less fear of humiliation or criticism. There's lower emotional exhaustion. There's greater job satisfaction and retention. And psychological safety can help protect against burnout. It also helps people cope with errors. Errors are discussed and not hidden. Staff feel supported rather than blamed or shamed. And it helps to support easier emotional recovery after incidents. And this is critical in the veterinary sector because we're already at high risk of moral stress. A psychologically safe environment encourages a focus on the system and not the individual. So imagine a car accident. The driver is immediately blamed. You caused the crash. It assumes human error alone is responsible. And the problem is treated as an individual failure rather than a system issue. Whereas a system-focused view looks beyond the driver to all the contributing factors. So what were the road conditions? Was it wet or slippery? Was there confusing signage? Were there any vehicle maintenance issues? Were the brakes worn or tyres worn down? What was happening with traffic flow at the time? Was there a complicated junction or a roundabout? And what was the weather doing? Was there a storm or something? So it's about asking what allowed this accident to happen and how can we prevent it? So in veterinary terms, a nurse almost gives the wrong dose. So we should therefore investigate the contributing factors for that. Was there similar packaging of the drugs? Was there a confusing electronic prescribing system? Was there a really high workload or low staffing numbers or interruptions? Was there a lack of an embedded double check system within the practice? Again, what allowed this error to happen and how can we prevent it? I want to spend some more time further exploring how culture impacts on psychological safety, although this topic could be a whole webinar in and of itself. So we'll just touch on it this evening. We're going to explore three types of culture that are often talked about, starting with blame culture, which is punishing individuals for errors. So the reaction to an error is who is at fault, and the impact on the team is fear, hiding mistakes, and low trust levels in the organisation. The outcome then is that errors are concealed and safety is therefore compromised. So an example would be a nurse making a dosing error and hiding it. In the 2000s, the focus moved towards what we would call a just culture. This was developed to address the limitations of the no blame culture, which was an improvement on a blame culture. It had strengths in encouraging reporting and learning from mistakes, but it somewhat ignored accountability and sometimes unsafe behaviour still went unaddressed. So a just culture focuses on balancing accountability with learning and distinguishes between different types of error and different types of behaviour. So when something happens, the reaction is, well, what type of behaviour has occurred? The impact on the team is that staff feel safer reporting errors and we still maintain accountability. This leads to errors being reported, systems being improved, and learning that actually happens. So the example would be a nurse reporting a wrong dose. A system and process for that process is reviewed, and if necessary, some guidance is given on how we can improve that process. More recently, since the sort of 2010s, a focus on restorative culture has emerged in healthcare and other high-risk industries. This focuses on repairing harm and relationships, and not just systems or behaviour. And it asks, who was affected and how can we make things right? So with restorative culture, staff feel supported, trust and relationships are rebuilt, emotional harm is addressed, and we strengthen our team's cohesion. So in our example, the nurse has reported the wrong dose, so the team discusses the incident openly, the nurse receives support, the lessons are shared, and relationships are restored. Restorative culture, with just culture focused on fair accountability, and restorative culture focused on healing, trust, and learning. We've talked about psychological safety and also about just and restorative culture. We can add civility to this, with much research having been done as part of the Civility Saves Lives campaign. Again, something that's a whole topic in and of itself. There are recorded CPD sessions on this topic in depth on our website, so please do take a look at this, and I'll touch on it a bit more later on as well. When psychological safety, just and restorative culture, and civility are present, teams communicate openly, we learn from near misses and errors, we improve our systems and processes, and staff feel supported and motivated. And this all contributes to the safety culture of the organisation, which is the observable behaviour and the mindset, what people actually do every day, not just what the policy says. When staff feel safe to speak up, when they treat each other with respect, and they know they'll be treated fairly if something goes wrong, the whole culture improves. And this positive safety culture makes it more likely that errors are caught early, systems are improved, and ultimately patients receive safer care. So this is how psychological safety protects our patients. Errors are caught early. Staff feel safe to question things like an unclear prescription, to double check doses, or to raise concerns about procedures. And studies show that psychological safety predicts the willingness to report safety events and of near misses. It enhances safer team communication. So teams are more likely to share critical information openly and consistently during handovers, during surgeries, during emergencies. And open communication reduces misunderstandings that could lead to mistakes. So misidentifying patients, miscalculating drug doses. And studies show that higher psychological safety is linked to better teamwork and communication, which are key contributors to patient safety. We have a more robust safety culture. Psychological safety is a cornerstone of positive patient safety culture. It's been found that teams where people feel safe to speak up and raise concerns have fewer adverse events. They have better adherence to protocols, and faster identification of system weaknesses. We have continuous learning and improvement. Staff are comfortable discussing what went wrong and why, without fear. This allows teams to learn and improve processes and improve patient care in the long term. It also supports ethical and compassionate care. When staff feel safe, they can advocate for their patients and question unnecessary procedures or escalate welfare concerns without fear of repercussion. So overall, when staff feel safe to speak up and challenge unsafe practices and learn from mistakes, the result is a team that can prevent harm, that can protect their patients and continuously improve the care that's provided. Psychological safety is not just about staff well-being, it's a direct contributor to safe patients. So what are some of the barriers to psychological safety? It doesn't usually fail because people don't care. It's usually blocked by workplace dynamics. These would include things like hierarchy. So in safety critical settings, we need a hierarchy. We need somebody in charge. We need a decision maker. But we need a flat enough hierarchy where everyone in the room has a voice and can raise concerns. Otherwise, junior staff may be hesitant to question senior staff. Nurses might be reluctant to challenge decisions by vets. Non-clinical staff might feel their concerns don't even count. These power differences can increase the fear of embarrassment, of criticism, or being seen as incompetent. And people might think they must know better than me. Another barrier is the fear of blame or punishment. Staff might worry that mistakes will lead to disciplinary action. People will avoid writing things down. Near misses go unreported, and speaking up feels personally risky. Protecting oneself overrides protecting the patient. Another barrier is incivility or disrespect. This could look like eye rolling, sarcasm, snapping under stress, criticizing people in public, dismissing people's questions. Even small behaviors can signal that it's not safe to speak here. People may then withdraw or stay silent in these situations. Another barrier might be perfectionism culture, this opinion that good clinicians don't make mistakes. That can then lead to shame or embarrassment around errors when they do happen, which can then lead to reluctance to admit uncertainty. And that admitting doubt feels like we're admitting incompetence. The risk is, though, that the questioner is not asked in this situation and the loss of learning opportunities in this kind of perfectionism culture. We have barriers around time pressure and workload that we'll all be familiar with. Rushed consults and handovers and constant interruptions and no time for debriefs. And speaking up might feel like slowing things down. Reflection and discussion get squeezed out when we're under pressure. And there's also the previous negative experiences you might have had. If you spoke up before and were shut down, if you had concerns ignored in the past, you might learn it's safer to stay quiet. The good news is, though, that most of these barriers are cultural and behavioural, which means we can take steps to actually reduce them. So how can we create psychological safety? What can we practically do to inform this more? Any improvement journey should start with an understanding of where we currently are. That acts as our baseline for improvement and guides our areas of focus for improvement. And there are several psychological safety assessment frameworks and tools available online that can help either individuals or teams with this, two of which I'm going to share with you now. The first is developed by Amy Edmondson, who I mentioned earlier. It's a 7-item assessment scale, which is a validated instrument used to measure the shared belief that a team is safe for interpersonal risk-taking. So it evaluates the collective perception of the team climate and focuses on whether individuals will feel like they'll be punished or humiliated or rejected for engaging in learning behaviours like admitting mistakes or asking for help. So the 7 items are whether mistakes are held against team members, the ability of members to bring up problems and tough issues, whether people on the team are rejected for being different, the perceived safety of taking risks within the team, the difficulty of asking other members for help, whether members would deliberately act to undermine another's efforts, and the extent to which unique skills and talents are valued and utilised. So there is like a questionnaire type thing online where you can answer these questions either as individuals or as teams to help assess your current psychological safety assessment. Another tool that's available is actually specific to the veterinary setting is the Nottingham Veterinary Safety Culture Survey. This is a validated psychometric tool that was developed to measure the safety culture within veterinary practices in the United Kingdom. And it was created to address the lack of veterinary-specific safety measurement tools. It's a 29-item survey that evaluates safety culture in the practice across 4 primary factors. So the first is organisational safety systems and behaviours. This is about the perceptions of how the practice structures its safety protocols and how it responds to errors. It also measures the staff perceptions of management, so gathers employees' views on leadership's commitment to safety and the support that's available for clinical staff. It measures the perception of risk, so are clinical risks recognised and things like personal stresses recognised, things like fatigue that may impact on patient care. It also measures teamwork and communication and tries to evaluate our efforts and openness of communication channels within the team. So this survey tool allows practices to compare their safety culture against industry standards, or between different branches or over time. At the Ralph, we've run this survey 4 times now, and I'm planning on running it again this year, so we can compare our progress over time and help inform our improvement plans. It helps to show where there are weaknesses in the team's safety mindset and to guide targeted training initiatives. It also raises visibility, even by just doing the survey, of issues like the fear of speaking up and the impact of burnout on clinical outcomes. So taking time to do some self-assessment is a really good first starting place to addressing psychological safety in your workplace. So having taken some time to do some self-assessment, what are some things we can do to improve psychological safety? So firstly, take a look at your hierarchy. Psychological safety doesn't mean having no hierarchy, but it means a hierarchy that doesn't silence people. So in your practice, do you have clear roles and decision-making authority? Is that very clear to everyone? Can anyone question decisions about patient safety? Are junior staff explicitly invited to contribute? So, for example, saying, if anyone sees something that doesn't look right, say it, even if I'm the one doing it. Try rotating who speaks first in huddles or rounds or debriefs. It's not always the most senior person in the room who leads the discussion. Next is leadership behaviours, and this is huge. So if you are a leader, take note. Leaders shape safety climate way more than policies do. Leaders need to model fallibility and to start talking about error, talking about the prescribing error they nearly made yesterday, admitting uncertainty as well, saying, I'm not sure, let's double check. These sorts of things signal that it's safe to be human here. Leaders need to frame work as learning. So, for example, at the start of procedures or clinics, saying, this is a complex case, there's an opportunity for learning here, let's share what we can learn about this case. Taking the time to discuss cases as learning opportunities, either in the moment or in structured sessions at a set time. Leaders need to respond well to speaking up. How we respond when someone speaks up or reports a concern is so critical in developing safety culture. So thank people for raising concerns, avoid defensiveness, follow up on the issues raised, as one poor response to speaking up can undo so much trust. Speaking up tools are useful to help facilitate conversations, and they're even more helpful if discussed and agreed as a team in advance, because we can agree how we're going to escalate concerns as a team. So the CUS tool is an assertive communication tool used in healthcare that's designed to help people voice patient safety concerns effectively. So it stands for concerned, uncomfortable, and safety issue. So concerned is stating your worry about a patient's condition or a potential issue. Uncomfortable is expressing your discomfort about the current situation or the plan. And safety issue is explicitly stating that this situation is a safety risk. Its purpose is to stop the line and to catch a decision maker's attention and ensure patient safety even when a team member feels the situation is unsafe. It's often used with a two-challenge rule, so where a team member asserts their concern at least twice if the initial challenge is ignored. It's particularly useful in high stress, emergent, or hierarchical situations. And also where a concern has still not been addressed after the S statement, it is advised that staff members should escalate through the chain of command. So an example of use is saying, I'm concerned about the patient's blood pressure. It's been dropping over the last few minutes. Or I'm uncomfortable continuing this anaesthetic without ruining the anaesthetic depth. Or saying, I think this is becoming a safety issue for the patient. The PACE model is another assertive communication framework used for graded assertiveness, and particularly in high stakes environments like healthcare, aviation, and emergency services. It provides a structured way for individuals, and especially those in junior roles, to voice safety concerns or challenge a course of action without being unnecessarily confrontational. The acronym stands for P for probe, so probing and starting with a non-threatening question or observation to clarify the situation. A for alert, expressing a specific concern if the probe doesn't lead to a change in action. C for challenge, issuing a more direct challenge or offering an alternative solution. And E for emergency, state the need for immediate action or bring in a third party if the danger remains. This is an example of PACE in action. So probe is testing if somebody's aware. So did you realise there's no EtCO2 trace? Alert is asking if we can reassess. So I'm concerned the ETT is dislodged. Could we reassess? Challenge is indicating that this could cause harm. So saying we need to replace the ETT to avoid hypoxemia. And E, emergency, is saying stop what you are doing. So stop, for the safety of the patient, remove the ETT. The PACE framework helps to raise concerns in a non-threatening way that does not cause confrontation, doesn't challenge or question the authority or seniority of the person being escalated to. It overcomes those power gradients by helping individuals speak up to authority figures by starting with low threat communication. It reduces that defensiveness that you might be worried about by beginning with a probe, which means the recipient has a chance to assess and correct without feeling attacked or threatened. It maintains safety by ensuring that critical red flags are not ignored due to social awkwardness or fear of being wrong, and helps create psychological safety by using a known framework, creates a culture where questioning is expected and professional. We also can seek how to build civility norms in our practice. So the Civility Saves Lives work shows that incivility isn't just unpleasant, it impairs clinical performance. Even low-level perceived rudeness can reduce our working memory, impair our diagnostic thinking, decrease our attention, and reduce our willingness to seek help. So incivility directly affects patient safety, not just morale. Civility signals respect and belonging. It reduces fear of humiliation, makes speaking up feel safer, and protects our cognitive bandwidth during complex tasks. And so psychological safety will struggle to exist in uncivil environments. So there's some practical civility behaviours from the campaign principles. Firstly, making respect visible. So saying hello, using people's names, thanking people for raising concerns, and acknowledging people's effort, not just the outcomes. We can protect people under stress. Now, stress increases in civility, but stress is common in clinical care. So simple reset behaviours include pausing before responding, lowering your voice and slowing your tone. Calling in rather than calling out. So stepping aside rather than raising something publicly, saying, can we talk about this case for a moment? I'm off to one side. This keeps dignity intact and maintains psychological safety. And leaders setting the tone. If senior staff snap under pressure, dismiss questions, or use sarcasm, it signals to everyone that it's unsafe to speak. But when leaders say, thanks for raising that, good catch, or let's look at that together, it builds safety and builds it fast. We also need to consider civility as a safety intervention of itself. So frame civility as not as etiquette, but as a patient safety behaviour. Because being civil preserves our team's cognitive capacity. When thinking improves, patient safety improves. We also need to normalise talking about error and uncertainty. People may hide mistakes due to fear of blame, shame, or hierarchy, but silence allows errors to repeat and to escalate, and it puts patients at risk. Open discussion creates learning opportunities and strengthens safety culture. So how can we do this? We start by framing error as system learning. So errors are usually symptoms of system flaws, not of character flaws. We need to start using near misses as teaching moments. So highlighting those almost events, not just actual harm events. And that reinforces proactive behaviour rather than reactive blame. Having debriefs and reflection time. So a short post-procedure or end-of-day debrief, what went well? What could we do differently next time? And needs to include all team members and encourage voices from all roles. Again, leaders modelling the behaviour, sharing their own mistakes openly, because that signals that admitting error is safe and expected, not shameful. And celebrate learning from error. So recognising improvements that have been made because a mistake was caught. We also need to think about designing our system to support speaking up. And by system, we mean everything you interact with to do your job. That's the people, the technology, the task, and the environment. This is where culture meets process. Psychological safety isn't just about behaviour, it's making it structurally easy for staff to raise concerns. Even the most psychologically safe team can fail if processes make raising concerns awkward or risky or difficult. Clear, simple systems normalise speaking up and remove barriers that are created by hierarchy or workload or ambiguity. So having clear reporting pathways. Staff should know exactly how to raise a concern, both formally and informally. That might be with incident reporting forms, be that paper or digital. At the Ralph, we use a simple no login Google form with a QR code that then gets uploaded into the bigger VetSafe system. Also finding opportunities to raise concerns at daily handovers or huddles in those more informal spaces. And also including anonymous options for those who feel uncomfortable speaking publicly. We need to build in protected time. So interruptions, busy consults, overlapping surgeries can make speaking up hard. So build in brief pre and post surgery debriefs, or short safety huddles before the day starts, or scheduling quiet time for handovers or checking prescriptions. Protecting even 5 or 10 minutes reduces risk and signals that we prioritise safety. Having checklists and double check systems is how we embed safe behaviours into our workflow and not just relying on memory. So medication double checks, pre-anaesthetic or pre-procedure checklists, discharge safety checklists, having surgical counts of swabs and instrumentation. When the system forces verification, staff can speak up naturally because the process supports it. Having accessible escalation protocols. Everyone knows who to escalate to if concerns are not resolved at the first level. It reduces the fear of going over someone's head while keeping escalation safe and structured. So consider having named speak up guardians within the practice so people know who they can go to. That's something the NHS has really embedded. Every trust, every hospital has named speak up guardians that people know they can go to anonymously and raise concerns if they feel they can't go to their line manager. Building in feedback loops. So staff who take the effort and time to speak up should see action being taken, or at least hear a reason if no change is possible. And this prevents demoralisation and reinforces more trust in the system and make it worthwhile to speak up in the first place. And also think about our environmental design, our physical layout of our environment, which can support speaking up if we have shared workspaces and open lines of sight for quick checks, also having private spaces for those confidential discussions that we might need to have as well. We then need to reinforce this message and repeatedly reinforce it. Psychological safety is not a one-off. Teams need repeated signals from leaders, from rituals, and from policies that speaking up is normal, expected, and valued. That repetition turns behaviour into culture, which then protects patients. So we can do this through our language as leaders and repeating key phrases in multiple contexts, things like "your voice matters," "if something looks off, speak up," and that near misses help us prevent real harm. And using both formal and informal communication methods. So formal things like meetings and emails, and informal settings like during rounds or during pre-surgery briefings. Having regular team rituals. So our daily huddles and handovers, and in those including an explicit check. Are there any concerns we haven't spoken up about yet? Having debriefs after procedures, where we discuss near misses, any lessons learned or any improvements we could make. And time for weekly or monthly reflection, celebrating examples of speaking up and any resulting actions that have taken place. Reinforcing through positive feedback, so acknowledging and rewarding speaking up, saying thanks for catching that, it helped to prevent an error. Public recognition reinforces it as a desired behaviour and it normalises it. So avoid giving only corrective feedback, make sure we're balancing learning and celebration when we're giving feedback. And also including visual reminders, so posters, checklists or screensavers, things like having things on them like "your voice protects our patients," and those tools I mentioned earlier like the CUS model, the PACE model, having posters of those sorts of things in clinical areas, which reinforces this is what we should be doing. I want to also touch on a little bit, take some time to reflect for anyone who may be in a setting where they feel psychologically unsafe on what you can do. So you can recognise that your feelings are valid. Feeling unsafe to speak up is common in strong hierarchical or high pressure environments. It's not a personal failing. The culture is the issue and not you. Use those established tools I mentioned about, the CUS and the PACE models, to structure your concerns. Even if it feels risky, it can reduce the perceived threat that someone might experience. And also document your concerns where appropriate. It might be in the clinical record as well. This is a good protective habit. Seek allies. Find someone you trust, a colleague, a senior nurse or a manager. You don't need to address the issue alone. A shared voice reduces risk and increases impact. If you can, escalate safely. Use formal escalation pathways if they exist. That might be incident reporting, or going through a practice manager or a clinical director or your HR department. Even if immediate change isn't possible, raising the issue in a documented, structured way protects your patients and staff. Also, prioritise your well-being. Working in a chronically unsafe environment is stressful, so monitor your well-being and consider talking with employee support programs, mental health services, or professional networks like support lines and peer support groups. Feeling unsafe will affect our mental health, and also our performance, and could affect patient care. So self-care and support are legitimate priorities. And look for long-term solutions. Sometimes cultural change is slow, so consider joining or initiating safety culture initiatives, or encouraging leadership to adopt psychological safety practices. But if the environment remains persistently unsafe, explore alternative opportunities where speaking up is welcomed. Because not everyone can change the culture alone, but small steps like structured communication, supportive peers, and safe reporting channels can protect patients and keep you safe. And if the environment continues to be unsafe, it's okay to seek a place where your voice is heard. So our key takeaways for safer patients and stronger teams are that we should be looking to speak up safely, raising those concerns early and asking questions that can prevent errors. Culture really matters. Civility, just culture, restorative practices will protect our teams and our patients. A focus on systems and not blame, and seeing errors as learning opportunities, and leaders leading the way, modelling openness and accountability, which then sets the tone. So there's one thing to leave with today, it's that psychological safety is not a nice to have, it is a patient safety intervention. It's not just about feelings or workplace well-being, those things do matter too, but it's about creating the conditions where the right thing is easier to do. And every time we respond constructively to a question, Every time we thank someone for speaking up, every time we focus on improving the system rather than blaming a person, we're making it much more likely that the next patient is safer. I've just shared some further resources for you in case you want to do some more looking into this. So the company VetLed works within the veterinary space on all things human factors, patient safety, and they run many courses, do practice visits, and deliver training. I believe they have a masterclass on psychological safety starting next month on the 16th of February. So if you're interested, have a look at looking into that. The book that I mentioned earlier was by Timothy Clark, The Four Stages of Psychological Safety. The work by Dr. Amy Edmondson, again, she was one of the main researchers in this field initially. The Civility Saves Lives campaign has so many resources on that aspect of this topic. And there is CPD on the RCVS Knowledge website as well on non-technical skills and patient safety and safety culture. And there are actually quite a few university courses now in patient safety and human factors if you are so interested.